Good afternoon. We will be starting the session shortly. So, do I have invite our chair, Dr. Gopal Pillai, myself, co-chair, Dr. BNR Subudhi, convener, Dr. Himanti Chaudhary. Are you there? Moderators, Dr. Chitra Ramurthy, Dr. Rohit Saxena, Dr. Tamilarsi, Dr. Pooja Sinha. Anybody there from the moderators? Panelists, Dr. Srinivas Joshi, Dr. Satyajit Sinha, Dr. Anaga Harur. Nobody is there. Judges, Dr. Birendra Agrawal. No. नहीं है डॉक्टर उर्मिल चावला डॉक्टर अशोक कुमार नंदा is there, yeah, he's there sitting there. Dr. Sugata Paul, yes, he's there. Dr. Aniruddha Maiti is there. Dr. Ratish Pal is there. All the three there. Dr. Kasturi Bhattacharya, Dr. Arun Khetrapal, Arun is here. Dr. Sandeep Nagwakar, good. Rajesh Sharma, Dr. Ajay Sharma, Dr. Mahesh Gopal Krishnan, right. Dr. Arun Kumar Jain. Okay, so each presentation, for your information, each presentation 4 minutes and 1 minute per discussion. Be stick to the time. Time is very important. All your presenters, please make it a 4 minutes presentation only. And any questions within 1 minute only, please, to be finish up the session within time. So be ready. Sorry, be ready. Dr. Dr. Daivat Singh. Shah, sorry, Shah. Dr. Okay, Hirika Gosalia is there?
She is not there. This guy is ready.
Okay, then Dr. Jitendra Jethani, Dr. John Janakara, Prasanna Venkata, yeah,
Hello.
I know. Dr. Daivat Shah. Yeah, okay.
Excuse me.
Dr.
Does
Aniruddha Maiti, you are the judge for this paper. Oh, sorry. Comment. Judge will, the judges are different. He will the comments. Question answer.
excuse me? The judges will mark all the papers.
Yes. John has come.
Good afternoon, one and all.
Hello, one and all. This video describes
So my innovation is about an SFIOL that is called a tuck SFIOL. Can I have the sound, please? Yeah. My name is Dr. Daivat Shah. Yeah. So
Hello, one and all.
sound is on.
This video describes an
Sound.
innovative technique of tuck SFIO developed at our institute. As a VR surgeon, I see all these kinds of subluxated IOLs and dislocated lenses in my routine OPD. The main aim for me in these cases is removal of the cataract or IOL, clearing the vitreous and placing a secondary IOL. So various techniques like the Yamane, the flange, the 4-point and of course the old-fashioned iris claws have been described in literature. So what is actually an ideal good secondary intraocular lens? Let me show you my technique. So basically I make two holes at 1.5 mm from the limbus, make two adjacent tunnels, take a 3-piece IOL, place it inside and remove the haptics from the hole and place it inside the tunnels. Sounds very simple, right? Yeah, it definitely is. And along with simplicity, it is also cost effective. So let me run you through one of the cases. So this is a case of a 50-year-old male who had a blood trauma and a secondary subluxated cataract. So here, 3 localized peritomies have been made and a 25 gauge system is used. Now, like in the routine SICS, we make a tunnel and place some visco inside, and once the endothelium is well coated, we remove the nucleus through a wire vectis. Once this is done, the most important part of this technique is doing a good anterior and a core vitrectomy. And once the core vitrectomy is done, I mandatorily check the periphery for any kind of breaks. Now, to lay the background for a secondary IOL, 2 holes are made at a distance of 1.5 mm away from the limbus at 3 and 9 position, that is just outside the root of the iris. Now, 2 partial thickness tunnels are made with the help of a normal crescent blade. Once these tunnels are made, an X-nit needle is taken from one of the holes and the end of the X-nit needle is exteriorized through the superior scleral tunnel. Now, the leading haptic of the 3-piece IOL is inserted inside the needle and that is exteriorized from one of the ends. Now, while exteriorizing, you see the yellow mark. That is something that is called the silicon stopper, and it will prevent the lens from going back inside. For the other side, the trailing haptic is fed to a max grip forceps, and it is exteriorized from the other side. Once both the sides are exteriorized, the haptics are actually snugly fitted or tucked inside the partial thickness scleral flaps. As you can see, the IOL is beautifully stable. The beauty of this technique is that it does not require a suture or a glue to fix the intraocular lens. As we see here, the post-op results are very pleasing in terms of visual acuity, stability of lens, and minimal pigmentation. To assess the nature of the haptic, at 1 month follow-up, we did an ASOCT at the level of the haptics, and we could see the haptics very nicely buried at 2/3 of the scleral depth. On the UBM, we can see that the lens is nearly in its physiological positions, and there is a sufficient distance from the iris. Hence, the chance of a post-op pupillary block is minimal. So, does our technique fit in the criteria for a good SFIOL? Definitely yes, it does. Certain complications that can happen are haptic protrusion, pigmentation over the lens surface, and tilting of the lens. So, till date, we have done more than 260 procedures, and our complication rate for the stuck SFIR technique is less than 4%. So, I believe this is a brilliant, cost effective, and easy to learn technique for secondary IOLs. Thank you very much for watching.
Thank you. Hi.
Comments or questions first?
Comments and questions.
Right.
Comments, questions, queries.
Dr. Shah, it's
Yes, sir.
nice technique, but
Thank you.
uh, what what is the rate of the decentration in this?
So the rate of decentration actually depends if you have made exactly, if you have made it at 1.5, the rate of decentration is less than 2%. But sometimes what happens, because we are in a hurry, we don't measure the distance of 1.5 from the limbus. And that is actually the reason for decentration that we actually saw in a 3-month UBM that we did post-op. So we have done around 250 cases, and now we have realized that if you are putting the haptics at an appropriate distance, the lens does not get decentered.
Okay, and regarding the extrusion of this haptic,
Extrusion, yes. So if the scleral tunnels that we made, the scleral tunnels have to be at least 2/3, like we do in buckles. If they are at a 1/3 length, the rate of extrusion is a little more. If they are at a 2/3 length, so that we saw on the ASOCT, and then we realized. So if yes,
Okay,
is it? Do you feel
John,
is it a better
John, you
Sorry?
can
better
get
compared to
ready here.
Yaman?
sorry,
Is it-
I feel it is definitely better than the Yamane. Two reasons for that. One is decentration, and second, I used to do a lot of Yamane as a VR surgeon. I felt at 3 months, 6 months, 9 months, the patient was a little uncomfortable with that, bulge of the haptic, and he used to say, "Dikh acha raha hai, but maza nahi aa raha hai." So that was So then with this technique, now I have a 3.5 year follow up. We have published this paper also, and it is well accepted now. So I am very happy with the results.
Thank you.
So as a VR surgeon, sir, I really prefer, but you can go. So my main concern is I want to check periphery in all cases, and if there is a lesion, as the sir would understand, I would want to laser it on table. But you can get away with the vitrectomy. You can do an anterior, and you can still do this technique.
Thank you, judges.
Just one question.
Yeah, sure, sir.
What was the actual innovation in it?
So the XNIT needle is made by Arvind, but they introduce XNIT from both sides, and they have made a different kind of a flap that has been described in that technique. I have made a different flap here, and the other side I am not using an XNIT. I am using a max grip. So you cannot say it is a completely a new technique. It's a modification
new
of
technique, but
yes,
not exactly innovation.
yes. It's a modification of an innovation. That is it.
Let us move to the next paper.
Thank you. Thank
Dr.
you very
John,
much.
Thank you very much.
So, judges, please note this is number 5, Daivat Shah, that you have to mark. Number 5. Next on stage is number 3, Dr. John Davis Akara. Yeah. And Daivat, can you take the certificate from
3D printing novel glaucoma drainage devices. Dr. John Davis Akra, Dr. Narayan Balakrishnan, and Dr. Anju Kuriak. No financial interest, Dr.
John? One second. Let's just stop. Yeah. We welcome Dr. Chitra, our chairman ARC. Yeah. And John's topic is designing and making an innovative 3D printed glaucoma drainage device. And Dr. Nandakishore will be the person who will be asking the question. Is he here? Okay.
Dr. Sugata Paul can ask the question. Okay.
Okay, John, let's start. Let's start then.
From the mind to the eye, designing and 3D printing novel glaucoma drainage devices. Dr. John Davis Akra, Dr. Narayan Balakrishnan, and Dr. Anju Kuriak.
No financial interest. Dr. John Davis and I are practicing glaucoma consultants make an innovative glaucoma drainage device to practice implantation of this device and help in future implantation of glaucoma drainage devices in everyday practice. The implantation of these glaucoma drainage devices and require a long learning curve. Attempted to make an interesting glaucoma drainage device which has been 3D printed and hence has been used in animal eyes.
3D computer aided design and 3D printing to design and print the glaucoma valves that we are talking about.
Next, Jitendra is ready.
To our
Jitendra
3D
Jitendra is
printing
ready.
lab in campus and use the resin 3D printer to print the model. A tube from a Venflon, an 18 gauge Venflon, to make the tube of the valve is inserted into the anterior chamber or partially. And did a conjunctival peritomy to insert the valve. The footplate of the valve is carefully inserted under the conjunctiva. Make sure that the conjunctival opening is big enough to accommodate the footplate. The footplate has a larger surface area than the cornea. The tube is left pointing upwards towards the cornea. The footplate is then anchored to the sclera by suturing through the 4 holes using vicryl sutures. The tube is then measured and trimmed with the scissors. The scissors are kept at an angle so that the tube is cut in a bevel shape. Once this is done, the next step would be to implant the tube into the anterior chamber. But for that, first we have to make a track using a needle, partial thickness through the sclera into the anterior chamber in case of phakic eye, and into pars plana in case of a pseudophakic or a phakic eye. So now that partial thickness tunnel has been completed, then next step is to insert the tube into the tunnel so that it reaches the anterior chamber. Once the tube is inside, we have to make sure that it does not touch the endothelium. That's all for the surgical part of the video. These are some of the other valves that we 3D printed compared to the first valve, which was actually quite big. Let us now look at some of these newer valves in detail. We basically designed 3 different models of valves of 3 different shapes and sizes. Fluorescein dyed through all the 6 channels in the valve conduit. This is observed under cobalt blue illumination under a surgical microscope. Here we can see the 6 conduits for the fluid to pass through the valve, and if you lift it up, you can see the external hole into which the tube is inserted. And bottom view, this has a raised area on the top through which the tube is inserted, and it has multiple channels which channel the liquid into the bottom. The plate itself has multiple holes to allow easy fluid pass through into the subconjunctival space. The fluid flow is as seen in this video. Hope this innovation with 3D printing inspires young surgeons to start doing glaucoma valve surgeries and also to design newer models of glaucoma drainage devices.
Thank you, Dr. John. Actually, it's an interesting concept that you have made, but I have few things. See, 3D designing and 3D printing is obviously a good technique for innovations because the cost is all on the CAD. You know, you just are doing it on the computer. So modeling is not necessary and you can just do it on your own. And after you design, you obviously do a manufacturing.
Yes, sir.
Now, there are few things which are little worrying to me. One is we know any valve implant, it is when it is patented. So you have to measure at what IOP the valve is active.
Yes, sir.
So in this, how did you measure?
So
Number one. Second, if you are printing through 3D mechanism, whatever stereolithotype or whatever design you are making, the finish is usually not good. So that might induce excessive fibrosis. Okay, that is my second concern. Please address.
yes, sir. So firstly, this design was mainly made for the wet lab and also to innovate on new design. So if you have an idea for a valve, you look at say RD or you look at AGV and you say, okay, this is not an ideal design. You have some other idea. You can try out different designs. And as you said, there is practically no cost involved other than your time and energy to design the things in CAD and to print it. It is surprisingly very inexpensive. The 3D printer itself is only 17,000 rupees, and if you look at the cost of material for a valve like this, it will hardly be 50 rupees because only that much material is used. So you make 50 different designs, you get only 50 into 50. So it's not very expensive to as an innovator to make new designs. As about the human implantation of this, right now this material is also not biocompatible, as well as the finish is not smooth, but you can use polyethylene glycol diacrylate or polyethylene glycol 40, and these materials are biocompatible. Once they are 3D printed, they would need to be tumble polished. You might have seen in Orolab or Apasami labs where they tumble polish the IOS. That has to be done. So once that is done, you get smooth surfaces and they can potentially be implanted. But you need not do all that. You can actually find a design that works and then give the same design
John,
to the
thank you.
company
I
to
think
finalize.
we'll make it a brief. It's done.
The discussion should be only for 2 minutes
Yeah, yeah.
because
1
we
minute,
have
1
the
minute.
next and then we have the
So
GBM.
next talk by Dr. Jethani, Dr. Jitendra Jethani, and for whom the discussion is Dr. Urmil Chawla.
Dr. Urmil, you are the discussant.
Please.
Certificate,
please.
John.
So, good afternoon, everybody. We will be presenting our.
Be louder.
Yeah.
So, good afternoon, everybody. We will be presenting our device on innovative device on measuring the amount of near work and myopic progress, and thereby measuring the myopic progression. Now, we all know that more we work indoors, more we do near work, the chances of myopia progression increases. There are multiple articles, multiple ways to prove it, how it does peripheral defocus and peripheral hyperopic defocus. We all know that near work and myopic progression go hand to hand. Slides are not moving. Okay, thank you. Now, right now, there are few similar devices available, but most of these devices do have sensors for GPS travel, temperature sensors, and they do measure the lightning. There's only one device, which is the cloud clip, which can measure near work also. Apart from this, there are no devices which can actually measure ambient light and how much indoor working it is. Even the cloud clip, which is available currently in the market, measures ambient light and thereby tells you how much indoor work you have done. They don't use a UV sensor, which is more important than ambient light, because if ambient light is high, the sensor may tell you that you're actually outdoors. If you're using so indoor lighting is classically around 1500 lux. So if you have a lux light of more than 3000 or 4000, typically it would say that this is outdoor lighting. So you have to use a UV sensor because ultraviolet light is completely blocked indoors. So that would be more accurate. So we are using a UV sensor here. And another sensor is a time of flight distance measurement sensor. This particular device can measure. So it starts measuring where your working distance is. So both the devices can be incorporated into a small device, which can be clipped on the temple of the spectacle when the kid is reading and writing. So one sensor would measure the ambient light and ultraviolet index in radians, and another would be measuring up to 5 centimeters to 1 meter, how much is the distance. Now, if we see these two videos, now he is wearing it, and he is using a near thing, and there's a live detection of how much distance it is and what is the ambient light, and the third thing which is coming is what is the UV index. So these three things combined would tell how much distance and how much indoor lighting it is. So but the problem here, the major problem here is that you can get raw data. The problem is we have to first find out how many seconds, how many times we want to collect the data. So that would be 6 times in a hour. That will be like 6 times in an hour. It will be 6 times, and then you have to find out a mean of that. And every reading has to have every minute there has to be 6 readings, which will be mean of that will be taken as that particular reading in that particular hour. So 1 hour will have 6 readings, and one reading will be a mean of another 6 readings. What happens with this is that all this will go into the microcontroller, which will save this thing. So that would require a battery, and that is what would increase the weight. What we have made the device, that particular device we have made, but what is the future of the devices that we can make 2 sensors on the glass. This is not, we have not made it. This particular thing is the future that I am saying. We can put the sensor on either side and put a small charging and output unit, and that way we can get the results. So thank you so much for the time.
Very, very nice innovation. Jitendra.
What is the how have you named it? Mossad. What is it?
So Mossad is basically a Israeli agency which detects
Agreed.
these deep things. So that is why we kept the
What
name.
would be the cost of your?
Madam, it is actually not, right now we are not into the cost, but honestly speaking, this is not something which is radically different. A similar device is already available. It is 20,000 rupees per device. So the main reason was to keep the cost less than 5,000 so that it can be more useful.
There's
It was
already
basically
a device for UV measurement, radiation.
UV measurement
You
there
said
are
that
from
it's not-
LVP there is, and
Yeah.
Shruti has also made. So those devices are very easy. So we have made a device. I think it will come in the next year.
Can it be used in outdoor also, this device?
Yes, yes.
So is it waterproof?
No, not in the water.
No, not in water, but otherwise outdoor.
Yes,
also
yes.
sometimes.
Outdoor we
Dr.
can
Santosh, can you
use.
come
We
forward?
can use it outdoor, madam.
Weight, yeah, exactly. What is
No,
the weight?
weight is the issue. We are making newer and newer versions to reduce the weight to less than 10 grams. Yes, exactly. So that is the main challenge. The children will?
Finger it, yeah.
Yes, yes. If the
It's
weight
very
is not.
accessible to them to touch it and play with it. That's right. Anyway, nice.
Okay, thank you, Doctor. Please collect your certificates. Our next talk will be Dr. Santosh Kumar. And discussion for this topic will be Dr. Kasturi Bhattacharya.
Good afternoon, everyone. So impression cytology has been one of the diagnostic technique for diagnosis of OSS. It's basically the indications of being various ocular surface disease like keratoconus sicca, pemphigoid, vitamin deficiency, and it is one of the modality for diagnosis as well as follow-up of cases of ocular surface scopus dysplasia. So what generally one of the study has quoted almost it has got a 70 to 80% positive predictive accuracy for diagnosis. That is the impression cytology. It allows the collection of epithelial cells from the surface with a minimal discomfort to the patient, and also the advantage it has that is it does help in preservation of limbal stem cells. So essentially what we do in impression cytology is we collect the superficial cells from the surface, send it for either histological analysis or depending on diagnosis, either for immunohistological analysis and at some places for molecular analysis. The various stains which are used for impression cytology is PAP stain, or also known as Papnicolous stain, hematoxylin and eosin stain, and PAS stain. Various collecting devices are used for the collecting cells from the surface are mostly used a cellulose acid filter paper, and one of the literature says a biopore membrane. We did not have access to this, any cellulose acid filter paper or any biopore membrane. So we went ahead and devised one technique, that is collection of cells from the surface using easily available cover slip, which is easily available in the lab. So the various requisites are just on the glass, the speculum. Cover slip is easily available in the lab. The tissue is taken from the OSSN under paracan. If the patient is comfortable, If the patient is cooperative, it can be done without paracan also, and it is plated on the slide. And after that, the job of pathologist, she can do the staining. In this case, the pap stain was done, which showed dysplasia in this patient. So this is a pre-procedure photograph of the patient, OSSN, and post-procedure photograph. Stain was used a pap stain. After this diagnosis, the patient was treated with interferon alpha 2b in the dosage of 1 millunit per ml for almost 6 weeks, and there was there was no OSSN after 6 weeks. So coming to the advantage this technique has, it is very cost effective. There hardly any cost involved. Covered slip is easily available in any lab, easily available, and there is no technical expertise required in this. Thank you.
Very, very nice.
Dr.
Very
Kasturi
non,
got the discussion.
simple, easy way.
Please give the
Loud,
mic.
Bob, with mic, please.
Very nice presentation. But how do you think that how safe it is to use a cover slip? Because sometimes we see OSSN, like they are in the melting stage. So you're using a cover slip. So how safe it is for the patient?
Maybe normally if you go deep, then it is at times might bleed. But in this case, I was very superficial, and
so it needs technical expertise. Like it's not that it is a reproducible surgery, a technique anyone can do it. So
normally, I mean, technical expertise means resident can do. Even resident also can do. So that is it.
Good.
Thank you.
Thank you.
I have one question.
Yes.
Sir.
Done without paraffin as well.
Sir.
Why would you do it without paraffin?
I tried with.
Change the diagnosis.
No, sir. What was the?
Why not keep the patient comfortable? Yeah.
Yeah, is it possible? What I said that it can be done without paracan also if the patient is cooperative. At times, the patient non-cooperative. So if you say the paracan
There
can
won't
be
be
used
any
on cases.
sensation on the cornea.
So it can be done with. I mean, with paracan, it always suggested that it should be done with the paracans.
Next talk by Dr. Vivekanandan.
Thank you.
And discussion for this topic are there two, Dr. Arun Khetrapal and Dr. Arun Kumar Jain.
We got, okay. Dr. Arun Jain is not there, so we need another discussion. He's going to be talking on managing dialysis repair CTR. So, will you do it, Dr. Arun Khetrapal? Okay. Dr. Vu, where is Virendra?
Virendra is sitting
Oh,
there.
Virendra is there and Dr. Ajay Sharma is there. Why, they should all be sitting in the front. ठीक है इसमें नहीं जजेस को आगे बैठाना है नहीं तो मुश्किल हो जाता है दिखे ही नहीं ठीक है डॉक्टर वीरेंद्र अग्रवाल और डॉक्टर अजय शर्मा को भी पूछना होगा हाँ
Please.
Shall I start?
Please.
Okay, good morning, everyone. So today I'll be talking about my new techniques for managing iridodialysis and scleral fixated IOL. Slide, how did it change? So the current techniques are cumbersome, involving peritomies, Hoffman's pocket, scleral flaps, and a couple of sclerotomies to interiorize and exteriorize the suture to knots. So this is our technique of iridodialysis. So this is a traumatic cataract with 3 to 4 clock hours of iridodialysis that we see. So after staining, using an iris hook, the iridodialysis is kept at bay, and then a rhexis is done and regular phacoemulsification was done. Fortunately, the bag was stronger, so we didn't need to have any CTR placed. So the IOL was placed. After this, the regular HPMC was washed, and a combination of dispersive and cohesive viscoelastic is injected into the eye to flatten the iris. In this stage, it is very important to use that viscoelastic than HPMC, because HPMC, the iris tends to roll down. So we want it to be flat. Then the iridodialysis area is marked and the points of anchorage is identified. Moving the conjunctiva radially, a spatulated needle attached to 70-proline is passed ab externo into the eye, and using a microforceps, the peripheral iris is held. It is pierced through the peripheral iris, and the same needle is exteriorized through the clear corneal incision that we made for phaco. And with the same needle, a U-turn is made outside, and the needle is introduced into the eye. In similar fashion, the peripheral iris, which needs to be anchored, is held, and by moving the conjunctiva radially towards the limbus, At the level of iris plane, the needle is exteriorized ab interno. So now you have a suture loop inside the eye. So both the sutures on the exterior are pulled till the approximation is achieved. Once the approximation is achieved, the first flange, the first suture is trimmed and flanged about 1.5 millimeters, and the other suture end is pulled so as to bury the first flange below the conjunctiva and tenoids. Similarly, once the approximation is checked again it is trimmed, flanged and buried. And the conjunctiva is ironed out, so you can see the 2 points of the flanges, whereas the conjunctival opening is much posterior. So it's a very simple way of doing iridodialysis repair. The instruments that we need is a spatulated needle attached to a 670 proline suture, a portable cautery. The advantages of this technique over the current techniques is no peritomy, easier and quicker learning curve, less time consuming, no flaps or pockets required. So these are post-operative one-day pictures of the iridodialysis repair. So we've done so far 8 cases in the last 3 years, and we've had no complications so far. So this is the second innovation inspired from Yamane and Canabrava's technique. We did our own flanched SFIOS, where we use the same specially designed spatulated needle. Is passed. It is passed. It is using an AC maintainer. The visco cannula is connected to the irrigation probe. It is brought out. The needle is passed through the dialing hole of the intraocular lens, the PMMA, regular PMMA intraocular lens, and the sutures are flanged till it becomes larger than the dialing hole itself. The IOL is interiorized, trimmed, flanged, and buried. Similarly, the second side is also trimmed, flanged, and buried. So the same procedure can be done with the foldable intraocular lens as well. So this is a case where the conjunctiva is fibrosed because of the previous retinal surgery. So here, 90 degrees away from the clear corneal incision, 2 sclerotomies are done. The needle is exteriorized through the clear corneal incision at the optic-haptic junction with the same needle. It is pierced. The sutures are trimmed, flanged. It is loaded into a butterfly cartridge, injected into the eye. The exteriorized sutures are pulled, trimmed, flanged, and buried. So these are my innovations with the flange technique. Thank you.
What suture are you using? Is it
So this is a needle and suture that we designed
10-0
exclusively.
proline.
It's a 7-0 proline.
7-0 proline.
Yes.
So do you think it is strong enough to hold on to the IOL and not pass through the opening you made in the sclera?
No, sir. So this needle, this is a needle that I designed. So this is a spatulated needle with 150 micron compared to the 26 gauge needle which we usually use for making the sclerotomies. That has a diameter of around 400 microns. Compared to this is half the size, and the incision is like a small slit. So the length of suture being flanged usually is 3 to 4 millimeters. Here it is just 1 millimeter.
And how long experience do you have? Follow-up of these
3
cases?
years.
3 years.
So so the scleral fixation, iridodialysis repair, and we use the same thing to fixate capsulotension segment as well. But that has been done already, so we've not showed that here.
Okay.
Yes, sir. It's available with Aura Lab.
And you showed fixation of a 3-piece IOL. So, and you pass the suture through the whole of the IOL.
Yes.
So what happens to the loops? Do they remain like this? Don't they
We've done
irritate
some dry lab tests to test the strength of the flange compared to the regular knots, sir. These are more than twice stronger than the regular knots that we use for suturing.
No. I'm worried about the free floating haptics of the PMMA haptics. Don't they irritate the ciliary body?
No, sir.
Or
We are actually positioning the IOL 2 millimeters behind the limbus. So they are not in contact with the ciliary body or the posterior surface of the iris. And the IOL power that we use is 0.5 diopters more than what we use as a PC IOL.
And what about the tilting of the IOL in such cases?
Sir, the advantage of fixating with the optic, dialing holes in the optic is when we use a regular scleral fixated
Dr. Neeraj
IOL,
can get ready on the podium.
Haptics have holes in it. There is a chance of tiltage. But here, the only chance is mild decentration if the first flange is a little too much. Only decentration we have seen, but we have not seen any. So
thank you.
For the IOS, 3-piece IOS okay. For single
No, sir, it is posteriorly, it is behind the level of PC, 2 millimeters behind the limbus. We, surprisingly, sir, very rarely you see iritis in these cases. We've done over 300 cases so far, and very, very few cases of iritis we've seen.
And in the market, there are single piece IOS available to use spec drape, so you don't have to puncture if you use those.
Yeah, now it is there, sir. The idea is to do with whatever we have. For a regular practitioner on a day-to-day basis, it's difficult for us to have a stock of all those lenses. In case we are planning, we can get those. If we can do this as a primary and secondary procedure as well. So as a primary procedure, we want to do something, we can still.
Dr. Neeraj.
Thank you, sir.
So next talk by Dr. Neeraj Israni and the discussion by Dr. Sandeep Nagwekar.
Okay, we can start the timer and the video. I'm Dr. Neeraj Israni, and my innovation is spec drape, which is a novel disposable speculum with eye drape. Yeah, start the video, please.
To use spec drape, a novel disposable speculum with eye drape. Post-operative endophthalmitis is the most dreaded complication for a cataract surgeon. Eyelid infections leading to contaminated surgical fields are the most common reasons for this. Improper draping, as seen here, is one of the leading causes for this. Hence, to put emphasis on proper eye draping, we need to first get rid of the conventional ways of eye draping. The steel speculum, on the other hand, is proven to cause eyelid tissue damage and lead to pain, ptosis, and difficult to put in deep set eyes. Thus, we had a research question so as to come up with a speculum and a drape combined to make it easier, faster, and patient friendly. Hence, we developed the spec drape, which has all the above features on a CAD file and 3D printed the first prototype. The spec drape not only has a draining outlet for the fluid, but is extremely elastic and designed to completely cover the eyelashes. Here is a demo of the spec drape on a patient. This is the 3D printed prototype, which is assembled with the adhesive skin part of the eye drape. The spec drape has an outlet which will drain the fluid into the pouch as seen over here. As you can see, once we strip off the plastic, like any other eye drape, it is adhesive to the skin. Further, the inner ring will go and engage in the lower and the upper tarsal plate. And since this is a 3D printed device, the stretch is not enough, but ideally it will completely stretch and give a very wide field of surgery to the surgeon. This is the CAD file for the latest prototype, which consists of two parts, which are joined together with the help of a screw. This screw will help us to increase or decrease the surgical field depending on the surgeon. Final autoclavable prototype is in works and will be available very soon. Thus, the advantages of the spec drape would be that it is less time consuming since it is a one-step procedure. It not only is a less cumbersome procedure for the patient, but also make sure that the entire eyelashes are covered, thus reducing the chances of any infection.
Thank you. So just want to add one small thing that we've already spoken to a leading drape manufacturer, and it will be autoclavable and available very soon. Hopefully made out of SMS and poly material. This was just a 3D printed materials for conceptual basis.
So Neeraj, yeah, thank you for the presentation. Very nice idea. In fact, I'm impressed that you're probably going to prevent the fluid getting into the drapes around,
Yes.
because one of the main problems for me is not the concern of the eyelashes putting the infection, which anyway you're sterilizing or preparing the patient. But the nasal side, very often it gets wet.
Pooling.
And when pooling takes place, the drapes get wet.
Yes.
And we know that on skin, if the drape gets wet, the sterility is gone.
Yes, sir.
So is this going to ensure that those parts will be completely dry?
Absolutely. So that is another good
Yeah.
point that I will definitely add in the next presentation when I make it.
Yeah.
And it will also be useful for intravitreal injections because it's just a one-step procedure, quick and faster also. And the thing is that only one catch that I had with this was that how to make it stretchable. So we found the exact material, and we're also trying to reduce the carbon load because, like how Arvind is doing, so we're working on a material which will have less carbon emission also.
Yeah. The second concern is, since this is at two levels,
Yes.
it's probably during phaco going to impair the entry of
No,
instrument.
sir. That we've worked up all. This was the
because-
first thing that
because
we,
it's quite broad.
This
And
is a 3D printed.
everything in phaco is like, you have to get in at the right angle and stuff
It's
like
going to be very minute, very thin. Only the rings made out of poly material will be the thick ones. So that we've sorted
that. And
out.
the third thing is I saw you, pulling the lids apart with your fingers.
Yes. So,
Again, the chance of contamination.
Yes. So with the bud, probably, or it's going to be so stretchable that you just have to ask the patient to look down with a bud just everted and it will engage into the tarsal plate. So yes, this video I've used my fingers. I realized it later, but you have
Dr.
to use a
Ashish
bud.
to get ready. Dr.
So
Ashish.
while the upper and lower lid are getting stretched, what about the nasal and temporal?
So the new model, if you see, we added a screw which will again be of poly. So it will open like a shivling, it will be open like this. So that part will be open, and then depending on the surgeon's compatibility, whatever the surgeon wants, he can open the field of vision or decrease it accordingly. So that problem will also be solved with a screw made out of poly material.
Right. Yeah. Thanks.
Thank you, sir.
Next talk by Dr. Ashish Bachao, and the discussion for this topic will Dr. Ratish Chandra Paul. Can you close that door, please? Not you, yeah.
Don't you come, don't waste time. You come.
Not you.
Good afternoon, everybody,
Who's judging it?
respected judges and panelists. I'm going to talk about an innovation in surgical training and next slide. Yeah, so I'm a consultant on simulation development for this company. The innovation is about surgical training. This is the only system which we have developed which has haptic feedback. By haptic feedback, I mean it gives the sense of real life surgical training. The tissue responds almost 95% in a similar way as compared to a real life surgical training. It is instructor led. Each report of each surgical attempt that you do, whether you do 100 or 200 in a day, gets reported. And we encourage you to practice until you can't get it anymore wrong. A bigger game changer in surgical training, and we aim to have confident surgeons, better skills, and excellent outcomes. This is the platform which I'm talking about. For this, we have worked extensively on making the surgical simulation for phacoemulsification, and I'm very proud to have it launched at this conference. The beauty of it is, as I said, it has instructor-led training. It has haptic feedback. The tissues respond the same way, whether you want to have the IOP high, IOP low, whether there is aqueous leak, chamber falling down. There are these guidelines which help you to know exactly where to make the incisions, whether it's a clear corneal incision or a limbal or even a posterior incision. And the way you make a capsular excess, how does the capsular excess feel when you do it, whether you use a cystitome or a utrata forceps. So all these steps have been taken into consideration. The best part about phacoemulsification development that most of my team was involved in was about making a foot pedal to begin with, and then going reverse with the team that we have. How does the tissue feel when you start trenching? How does it feel when you make the trenches deeper? What do you see? What are the complications that a novice surgeon would entail? So it tells the real-time position of your haptics. If you see, there are training tools which tells you where your position is, where your hand pieces are. So all these come into picture and make this attempt very normal for a novice surgeon. It's not just for the novice surgeons, it's also we encourage people who want to enhance their surgical skills to come back and train. So for the first prototype for this conference, we have the divide and conquer technique. We are adding iteratively, step by step, the stop and chop and the direct chop techniques as well. So all the things that a surgeon would involve in a phaco, especially a peristaltic pump, have been incorporated. So you have the same settings. You can play around with the settings. You can add occlusion. We have sounds. They are not playing in this video, but all the occlusion sound or the phaco emulsification sound, everything has been simulated. So right from making the incisions to cortex aspiration to injecting an implantable foldable intraocular lens is simulated on this platform. So this is in itself is a complete training package, especially post-COVID era where the opportunities for surgical training have gone down. This comes in between that. So before you move on to live surgical mentor training, this training helps you do better. We have done this on SICS platform. There are validity studies that have proven that it is the way to go. Simulation-based training enhances skills, reduces complications, and better outcomes to patients. We have already have this incorporated in some of the major training institutes worldwide. Arvind L. V. Prasad in India. It is definitely a bigger game changer in the sense you have more confident, happy surgeons, happy trainers, and in the end, the outcomes are good because nobody is experimenting anymore when they are doing live surgical training. I thank you for your attention.
It's good presentation and good innovations. Tell me two parts. How do you control it remotely? Means once the trainee is in one place in the training.
Yeah. So we have a remote training option also. So we go back to an institute, train their instructors. They are also there on site. But we have our own people looking from it remotely. So we have a live session going on and instructors guide you to do the training themselves. Yes. So beginning of the training, we go there. Once we are comfortable knowing that one of the instructors on site who happens to be a senior surgeon and somebody who's going to do live surgical training with them is there, then we come back and then we do a remote training session. We have a data system which is called the performance management. So each performance management will load minute details like length of the incision, whether there was an endothelial touch, iris touch, did you inadvertently make anterior capsular touch. All these things get recorded. They are weighted. There is a performance metric which labels the attempt as satisfactory or unsatisfactory. So based on a 75% or 80% score of being satisfactory, we say, okay, you've done well, you can move to the next step.
Dr. Uday Mohan.
How are you connected with this, your company and you innovated?
I am the tech guy. I'm actually a cornea consultant. I finished fellowship from Arvind, but I'm involved with them for the past 7 years. I give specification, my team gives specification about how much IOP it should be, what should be the incision. So in a way, yes, it is my, I am not funded it, but I am thoroughly and deeply involved in its development. So yeah.
Already available in the stall.
Please, everybody is welcome to visit stall 123B and take a demo.
Okay, thank you, Dr. Assis.
Thank you.
Please collect your certificate. Please collect your certificate.
Collect your certificate. Vel Murugan, take a photo.
Next talk by Dr. Hidya Mohan and discussion for this talk to Dr. Ajay Sharma.
Dr. Ajay.
Good afternoon, everybody. I'll be presenting my video, Cystitome Phacochop.
Dr. Prasanna, are you there? Please start.
Cystitome Phacochop. In this novel technique, the 26-gauge cystitome, which is regularly used for creation of capsular excess, is also used for rotation of nucleus and also chopping of nucleus. The sharp tip of the cystitome makes it an excellent chopper. Here, chopping is performed within the confines of a rhexis margin, so that the sharp tip of the cystitome does not cut through the rhexis margin. Once the nucleus is chopped into multiple fragments, these fragments are emulsified as in regular phacoemulsification. This is the cystotome chopper used in the previous shown case. It's comparable to a short chopper, but when compared to the long chopper used in dense cataracts, the cystotome regular chopper is much smaller. In order to create a longer cystotome chopper, a 26 gauge needle can be bent a little away from the tip at the bevel. This gives adequate length to the cystotome chopper. Now it's comparable to the long chopper used in cases of dense cataracts. Here I have created a long cystotome chopper and it is used for chopping of this mature cataract. This is another case of a dense brown cataract with a leathery posterior plate.
That's good.
The long cystotome chopper is pretty effective in getting through and through crack in the center. Once a central crack is obtained, multiple cracks are again made using the long cystotome chopper. Once the nucleus has been chopped into multiple fragments, each of the fragments can be removed effortlessly. And there is no attachment in the center. Cystotome chop is an efficient technique in nucleus disassembly. It's cheaper alternative and it is more useful in denser leathery cataracts and helps in attaining full thickness cracks. Thank you.
Dr. Ajay Sharma, please. Dr. Prasanna, get ready.
Hello. Yeah, so you've used the same 26 gauge needle here?
Yes, sir.
And which is readily available?
Sorry, sir?
Which is readily available, the same
yes,
needle you have
the
used.
same needle that is
Then
readily
the
available.
second thing is, I think it needs a lot of learning curve because here the chopper, what you're chopping is not direct, it is a sort of because it is bent, needle is bent, you have to bend the retins and it has to be a sort of a horizontally, it is bent. So, and you are doing more of a vertical chop, so you can't use it for horizontal
No,
chopping.
sir, it cannot be used. But it should be within the confines of the Lexus margin.
Yeah. So, how do you feel the learning curve? Because I think this is for someone who is very expert in doing a phaco surgery, and why would someone need to do a thing like this and not have a chopper instead? That is my question.
For me, from my personal experience, for me, leathery cataracts, dense Brunison cataracts with leathery plate, I find it a little difficult with choppers even, sharp choppers even. But somehow with the cystotome chopper, I feel because of the sharp tip, it's and multi-level, multi-planar holding, the through and through cracks, I'm able to get it better with the cystotome choppers, longer cystotome chopper. I feel it's more useful for dense and Brunison
The
cataracts.
tip again is very sharp, so it can cause a
One needs to
precedent.
be careful, sir. Yeah, one needs to be
Yeah,
careful when
I
using
used to use this in 2003.
Yes, sir.
Now, problem with that, you have cutting edge in the side as well. And once it touched the capsule, it got to the posterior and I had a nucleus drop and I stopped. I think when you have good choppers available with side cutting chopper, the side cut of the needle is not required. So this
So when there are more cases posted in the OT and sometimes when the chopper is not
no,
working.
a chopper is handy rather than you are wasting time in bending the needle.
Yes, sir.
Yeah. And I gave up after the nucleus
So
drop.
I had one case of Rexus tear using this cystitome chopper, but then I converted the case to a
Yeah,
SICS.
because you have the cutting edge of the needle
Yes.
on the side.
Yes.
The moment it touch, it will extend.
Thank you, Dr. Hidya.
Thank you, sir.
Please collect your certificate. Next talk with Dr. Prasanna Venkatesh Ramesh.
Dr. Matthew, you could be seated.
And Dr. Virendra Agarwal will do discussion for this topic.
Dr. Virendra Agarwal.
Can I start, sir?
Yeah, please carry.
Mine is an innovative surgical simulator which was self-built by us, and we have also got the patent for the same. So MIGS is something that is taking the field by storm, especially for glaucomatologists. So this is one of my patients where I stent inject. I place the inject very well, but when I'm using the sodium hyaluronate or the Elon, can see how it just went away and it's just floating there. So I'm then placing the second stent and I'll have to retrieve the second stent again. And since I had two more extra clips, and again you saw when I took it out in the initial phases, it's quite complex when you lose a stent. So it just got caught in the incision and then I was able to place the stent very well. So this microsurgeries, they need lot of precision and they need lot of hand-eye coordination development. So we wanted to make a lot of simulation. So I have my own metaverse lab and I've been doing extensive work in that. So we felt we had to make a simulator for an MIGS because it is something that is taking the field by storm. So this is the AR headset that we have, and you can see how we are doing the coding. So this is like real time on the right hand side. So especially micro surgeries like minimal invasive glaucoma surgery, which is very highly talked about because of the results it's producing, especially the eye stent and the eye stent inject, and even the eye stent infinite that is going to be launched very soon in India. So you can see here, this is hand-eye coordination training that is being done by the neophyte before the surgery is being placed. So when he places the stent correctly, there has been a simple cue that is given that you can see a green color hit comes up. If it's wrong, it just doesn't light up. So these are some hand-eye coordination tools which is very important, I feel, so that you can have a good final placement of the stent. As you can see here, before you make a mistake, you can actually do these things because not many people work on. We have simulators for cataract, we have for phacoemulsification, but MIGS is something that is very, very upcoming in the field of ophthalmology. So this is again one of the patent protected technologies of ours, where we did analyze the wet lab training of this novel simulator versus the wet lab training. The survey is it's very early to say, but the results are very fair. I won't say it's so superb or anything, but neophytes feel that definitely the hand-eye coordination is better for the MIGS surgery going forward. They are satisfied to a very good extent, as you can see. It's a very small sample size. I just did this among the first year and second year residents of my institute. They are around 9 in number. And the simulator training, you can see that it doesn't say that the confidence improves during surgery. They still feel surgery is surgery, but this just gives you a good orientation. Mistakes, yes, the most of them told no, unless it's a real time. The rating, how would you say it is? It's 3, 4 to 5. That means they feel it's much better if they get a good hands-on view before the surgery is done, because the risk of harming the patients to an extent is minimal. And would you recommend this kind of simulator? Especially, you can see that today, if anybody wants to use it, it's cost effective, it's portable. You can have it on your head, and I can just show how we did the G1 simulator. If somebody does it 10, 15 times, they can go forward and then they can place their G1 tomorrow if they are oriented well with their direct gonioscopy technique that they have in the OR. So this is something that we say as the world of metaverse, and we are working extensively on it. And this is a self-created MIGS simulator that I wanted to present today. And we also use own images. So there are many augmented reality modules that come. We are using their own fundus images, and we are using the patient's own gonioscopic pictures for the angle as well. So that is where we specialize in. And this is my innovation that I wanted to present to the Elite panel on MIGS, which is very much upcoming. And this is a cost-effective, patent-protected 3D MIGS simulator for ambidextrity training and for neophytes. Thank you.
Nice, Pranesh.
Dr.
Yes, Dr. Virendra.
Yeah, mesmerizing. Very
Yes.
good. But I think you are doing only for the glaucoma valves?
Sir, the glaucoma is something that the other competitors, especially we have our own startup, sir, now. I'm an eye doctor, but I do have my own department. So glaucoma is something that I specialized in. And SACS and cataract in phaco, many people are taking up that job. This one in MAGS, when it took India by storm, especially the suture GAT also, the microscopic level of that surgery demanded a good simulator, sir. That somewhat fill in the blind spot of the people who are making simulators, because there is a lab which makes a simulator for cataract, but I felt because of the simulator thing, not many people are taking up MAGS. That's why MAGS is still not went that forefrontier as compared to the other one. So I am currently making MAGS, but I'm working on SACS and phaco, which is still not ready, sir. At least in my hands, I have not made it ready.
No, as far as I could understand, you don't require an eye in this. You are just using your hand-eye coordination. So
Yes,
if
sir.
you make it for cataract,
Yes, sir.
it will be very cost effective, because in cataract you require many other things.
Yes,
If
sir.
it can be, feeling can be done through that. So that was my
Yes, sir.
concern.
Yes, doctors, come forward and sit down.
Yes, sir. For even this kind of simulators, or even the smartphone, we are currently launching it. Metaverse is something I'm exploring in a very different level, sir.
Yeah.
And this simulator is, as you told, it's very cost effective, sir.
Yeah.
Even with the headsets that you have, Jio is launching their own headset for 30,000 or 40,000. And its portability is something which is very useful. You don't need to be anywhere. You can just, even after the end of the session, I can show you a demo if time permits.
Yeah, I agree. What I'm just worried about that when you do simulation, if your hand moves in between while you're injecting something, because you're not having any pressure feeling when you inject the stent or something. So that feeling may change your actually the placement. As you show the first case, you are in the right place, but after injecting, it was not in the right. So I think that simulation cannot be felt with this until there is something physical.
Sir, there is a technique called, if you see the headset where we wear it in the ear, there is a technique called haptic sensation or haptic stimulation. When we type messages in our phone, you get that click sound. You get that.
Yeah.
Similarly, when you place it in the right plane, there is a click sound that you will hear. That means it's in the right plane. So there is as much mimic as possible in the ear, especially that haptic
No, I
click.
agree, but when you put the stent, you have to
Yeah.
first localize it and then press it.
Correct.
So that pressure will change your hand position. But still,
True, sir. True, sir. Yeah,
still
nothing
a
like
very
a
good
real,
approach.
real skilled surgery, but
But
this is to an extent it will help us in
yeah, I think, but you should
addressing
have
the
one
issue.
team working on cataract. That will be much more useful.
Yes, sir. Yes, sir. We are trying to focus on MIGS for
But a
now.
very
But
good
yes,
innovation.
thank you,
Very
sir.
good.
Thank you. I would request all the judges come and collect your certificate from Dr. Virendra Agrawal. Go to Dr. Virendra Agrawal. Ah. I request all the judges and whichever speaker who is here to come to the dais so that we take one photograph. Yes, all come in, come, come, come. No, we learned something more. Come.